Patients in neurocritical care tend to be severely sick. Their brain has been injured, either through an accident or through a stroke or otherwise. And they do tend to be very, very heavily monitored. So even among the patients in critical care, those in neurocritical care actually do tend to have the largest number of signals monitored from the cardiovascular system, the respiratory system, but also the brain itself. The kind of monitoring modalities for real-time monitoring that we have from the brain are actually fairly limited. A particular one is intracranial pressure. So that's the pressure that surrounds, or of the fluid that surrounds your brain, so the cerebrospinal fluid pressure, essentially. The way that it is currently being monitored in patients with severe traumatic brain injury, for example, is that you take a drill, you drill a hole into the skull, and you advance the catheter in, towards the center of the brain, and you measure the pressure in one of the fluid-filled spaces inside of the brain called the ventricles. It's very, very invasive, and you would only do this in a patient who is very severely sick, even though a much larger pool of patients could actually benefit from knowing this important vital sign. So one approach that we've taken here is to take two easily obtainable waveform measurements. One is arterial blood pressure, the other one is transcranial Doppler-based measurements of cerebral blood flow velocity. We have a model that relates the physiology of intracranial pressure to these two measurements, and so then we actually estimate intracranial pressure non-invasively. We're currently validating that approach, collecting data for the validation step at various hospitals here in the Boston area, Boston Children's Hospital, Beth Israel Deaconess Medical Center, and Boston Medical Center. So some of the challenges that we're facing is building a model at the right size that allows us to robustly estimate this parameter. So that's the mathematical problem. The other problem is getting at the data, because the intensive care units are not set up to archive that data. The data that we want to have access to is actually not considered part of the medical record. So the waveforms that you actually see, whether it's an ECG, it's a blood pressure waveform that you see at the background in one of these monitors, going by, they're only kept for about 72 hours or so. So whenever we actually get into these environments, we actually have to figure out how do we actually archive that data. And so there's a technical challenge, because not two intensive care units in the Boston area are the same, use the same equipment. So we actually have to figure out how to interface to their devices. And then obviously there are human subjects regulations that you have to adhere to. You have to go through the ethics boards to be allowed in the environment, to be allowed to actually collect that data. In order to determine whether a modeling approach like this is useful, you have to validate. And ideally you would like to validate against different patient conditions, meaning different pathologies, different age ranges, but also from different sites, meaning different hospital sites. So the amount of data that you have to collect is not fixed, but it's quite sizable, in the sense that you actually have to demonstrate to the medical community that the measurements or the values that you estimate are ideally no worse than the invasive measurement. So there's a lot of learning that you will have to do from the data. There's a lot of, in different conditions, different features of the data might actually be relevant. So that's why it's important to actually look at different patient populations, right? And ideally, you also want to make sure that you can actually use the approach in a patient that is 3 years old, as well as in a patient who is 93 years old.